Good evening, friends. On behalf of MAHAIP team, I welcome all of you for this unique webinar that is MAHAIP Case Challenge. Today, we have Dr. Vasant Khaladkar sir as a guest of honor, Dr. Sachin Gaikwad sir as a MMC observer, and today's experts are Dr. Baldev Prajapati sir and Dr. Mahesh Moite sir. I welcome all these dignitaries for this unique session. As you all know, Dr. Mahesh Moite sir started this unique concept last year and it was a big hit. And now this year, Dr. Pramod Kulkarni sir has taken the lead, and along with Dr. Ramakant Patil sir and joint coordinators from different corners of Maharashtra, we are going ahead with this MAHAIP Case Challenge. Today, we have two case presenters and two teams from MAHAIP to crack the cases. Today's session has been granted 1 MMC point, and for all MAHAIPians, it will be free of cost. So attendance is compulsory, and I wish all the best to both the teams for cracking this case. So now I hand over to Dr. Neha Singh for further proceedings. Over to you, Neha.
Thank you, Amol sir. Good evening to all the respected dignitaries, seniors, and my dear friends. Welcome you all to the second episode of MAHAIP Case Challenge Season 2. I, Dr. Neha Singh, co-chairperson of MAHAIP Women's Committee and practicing pediatrician from Navi Mumbai, Raigad district, as well as my partner, Dr. Anjali Gokarn ma'am, senior pediatrician from Palghar IIP, also ma'am is executive board member of MAHAIP, will be the moderator for today's case challenge. Now I request Ramakant sir has joined. Amol sir?
Yes, ma'am. Yes, ma'am.
Yes, he has joined.
Yes.
Now I request our MAHAIP president as well as IIP executive board member, Dr. Ramakant Patil sir, to please give us blessings. Over to you, sir.
Thank you, Neha. I welcome today's guest of honor, Dr. Vasant Khaladkar, the academician, teacher, Dr. Baldev Prajapati sir, my friend, philosopher and mentor, Dr. Mahesh Moite, for being experts for this case, MAHA Case Challenge. And under the aegis of MAHAIP, Raigad IIP, Dr. Mahesh Moite has started this MAHA Case Challenge. And on the footprints and footpath of all these last year's MAHAIP the office bearers, Dr. Pramod Kulkarni has graciously accepted this responsibility and ably supported by Dr. Anjali Gokarn, Dr. Trupti Mahatme, and Dr. Neha Singh for bringing out this MAHA Case Challenge into reality. I appreciate and welcome today's presenters, Dr. Vaibhavi Barot from Palghar and Dr. Abhijit Joshi, pediatrician and intensivist from Chhatrapati Sambhaji Nagar. And today's two teams of Jalgaon team, I wish them all the best. I think Neha will take out the lots. Which team will face the presenter and crack the case? So we all are eagerly waiting to have this case being unfolded. And I thank again all the experts, both the experts and Dr. Vasant Khaladkar for being a guest of honor today and participating team and Dr. Pramod Kulkarni. I hand it over back to you, Dr. Neha.
Thank you, sir. Thank you for your blessings. Now I request Dr. Pramod Kulkarni sir, the coordinator of MAHAIP Case Challenge, to please give us a briefing about the case challenge. Kindly unmute, sir.
Welcome, everybody. And this is the second session of our interesting, exciting case challenge. And today we have two new experts, one guest of honor, and two teams. And it's all new two cases. So let's go ahead with the exciting thing. Here the experts today are Dr. Baldev Prajapati, who is the iconic teacher, as we all know, over decades, and another iconic pediatrician and brain father of this program, Dr. Mahesh Moite. Today we are fortunate to have both the teams, one from Jalgaon and one from Bid, and two fantastic cases. So not to wait anymore, let us go ahead with the case presentation soon. I will request the experts to give their inputs just to navigate the case discussion, and at the end of it, And I request all the attendees, please not to give any clues in the chat box or otherwise to the teams, because they are more than able to crack the case. We are very confident of that. Please support that, and thank you very much for being here. Back to you, Neha.
Thank you, sir. Now I welcome our guest of honor of today, Dr. Vasant Khalatkar, sir. He is senior most pediatrician from Nagpur, director of Colors Children's Hospital of Pediatrics Intensive Care, Nagpur. Sir is chairperson of Pediatric Infectious Diseases IIP Chapter 2023, immediate past chairperson of Academy of Pediatrics Neurology IIP Chapter 2022, organizing chairperson Pedicon 2018 at Nagpur. Sir was also Central IIP EB 2009 and 10, 2014-15. Sir was editor of Pediatric Neurology Bulletin, national trainer at various IIP programs, and recipient of several awards, national as well as international levels. Now I request Dr. Vasant sir to kindly unmute and give his message.
Thank you, Neha, for my brief introduction. I really want to thank MAHAIP and Raigad IIP for this upcoming program. Our teacher, Dr. Baldev Prajapati, who never say no, never, I will say. Suppose I'm talking about my experience. There was a program and I called him 2 days before, sir, I'm not getting any faculty. Came from Ahmedabad to Nagpur. Just the one call he came for, one day he prepared Vasant academic के लिए कहीं भी जाने को तैयार हो. Our Mahesh, definitely everybody knows, nothing to say. Mahesh, when Mahesh is there, Maha Academy, MAHAIP, कुछ भी हो सकता. Pramod is father of so many modules. मैं तो father ही बोलूँगा that whether it's ultra, whether it's a APME in ID chapter. So always we want Pramod. Always thank you, Raigad IIP President Amol, mainly Ramakant. I want to say thanks. And really, it's a fantastic program. I was looking after initially when I joined, there were only 50 participants. Now it's a graph is going high. Then people were saying last time it was 100. I think this time it will be definitely more than 150. So there are so many programs, but this program is definitely very famous program. And I wish all the best, all the best to team also, both the teams. And we are having expert to break this session. Definitely. Thank you once again. Thank you.
Thank you, sir. Now I welcome and request my co-moderator and partner, Dr. Anjali Kokan, ma'am, to proceed with the.
Thank you. I'm Dr. Anjali Gokan. I practice at Vasai. I am president of IIP Palghar. And today, it's a great honor to be here amongst so many dignitaries. My hearty welcome to all of them and gratitude for being here. Today, it is Sone Pe Suhaga. So we have not only a Maharashtrian team, we have also a Gujarati team. So we have two experts over here, Dr. Baldev and my very good friend, Dr. Mahesh Mohite. Dr. Baldev Prajapati, he is a head of department and professor at GCS Medical College at Ahmedabad. And like said before, he is a teacher of teachers. I have attended several of his PG, and they are it's a treat to be on that. He has been IIP, Central IIP EB member. He has been chairperson of the ID and ACVIP. And he also has written several chapters, 55 chapters in books and 47 articles in journals, and has given more than 2,000 academic talks. Such a great expert present amongst us today, Dr. Baldev. A very big hand to you. Welcome. And I request you to say a few words of encouragement to our participants.
Good evening, friends. Thank you very much, Madam Dr. Anjali, for kind words. It is always my pleasure to participate in MAHAIP activities, particularly the academics. Recently, just my wife informed that Amitabh Bachchan is coming with a further episode of the KBC, and MAHAIP team is coming with the say, second episode of this challenging the case, and I'm sure that it will be continued till the KBC is there. It's definitely quite exciting. All of us know that the best learning for all of us is the case discussion, and that is the, I would say, best methodology in the clinical medicine, and that is adapted very appropriately. And I came to know that it was thought of and even planned, and it has been started by Dr. Mahesh. All of us know him, very dynamic, very, I would say, meticulous academic person, and we know that he's best clinician. Therefore, this, I would say, idea can be conceived by him only. Thank you very much for inviting me and even giving the opportunity to learn in this from the discussion. Thank you very much. Over to you.
Thank you so much, Dr. Baldev. It's so humbling when you say an opportunity to learn. With that, I would like to introduce someone who really needs no introduction, and that's Dr. Mahesh Mohite. Before I say anything about his academic achievements, let me tell you that I have been with him on several, conferences. And there are two things he takes to conferences always. One is his running shoes and a list of cases he has found difficult to crack to discuss with international and national experts. So that is the kind of person Mahesh is. And you may know all his academic, but do you know that he is also a marathoner? So Dr. Mahesh runs marathons academically as well as in real life. So you all know that he is a pediatrician and neonatal intensivist at his own site childcare clinic as well as at BJ Wadia Hospital. He is right now the president of IIP Intensive Care Chapter as well as a council member of the Pediatric Critical Care. He has been awarded with the PM Udani Oration in 2021 and also was with the Sanjeev Rai talk at Mangalore. So Dr. Mahesh is a great academician, pediatrician, a great parent, and also a great entrepreneur and also a marathoner. So I welcome Mahesh to say a few words of encouragement for participants on both the teams.
Thank you, Dr. Anjali, madam. Actually, Anjali was my registrar in Grand Medical College. So yeah, I'm humbled by the way you introduced. Thank you very much. Actually, I was just wondering, in 2020 Mahapedicon, we planted a small sapling of this Case Challenge, and it just became a popular thing. And I'm really pleased that the next president, Dr. Ramakant and Amol, thought that it is really taking up, and I'm really happy that it's still living after 3 years and it's growing also. Not only living, it's growing also. So this concept basically came because we thought that on a conference panel, most of the times the cases are known through the panelists, and it's many times looks like a fabricated discussion. So I kept it for myself that whenever I'm on the panel, I'll not ask for the cases. And if I'm a moderator, I will not give the cases. So sometimes people used to be scared of taking me as a panelist or either way. So I thought, let's create another kind of a thing where it will be a raw case. Now, today, whatever cases, 2 cases, even the receiving team don't know which case they are going to face. And the delivering team also don't know which team they are going to face. So this is how we want. So this will be, ultimate thing is only approach. What is most important approach? It's not essential that you will always make a diagnosis. The approach is very important. So again, thanks Dr. Ramakan, Dr. Amol, Anjali and the whole team. And of course, my teacher, Dr. Baldev Prajapati sir, and Vasant Rao. So thank you very much for giving me this opportunity to be an expert here, and I'll try my best to prove the mental. Thank you very much.
Thank you so much, Mahesh. And there is a request now to Dr. Baldev Prajapati. Since Mahesh told you that it's a big secret which team will face which presenter, I request Dr. Baldev to draw the lots so that we know which will be team 1. Team 1 will be facing Dr. Abhijit Joshi.
Sir, you have lifted one cheat.
As far I'm guided by Dr. Amol, I have prepared the 2 cheats with the names of the teams. And now as you wish that I should take one of them, and in the right hand I'm taking it. Should I unfold and read it?
Yes, sir. Yes.
Yes, sir.
Okay.
And the award goes to
It is a bead.
Bead.
Ah, lovely. So, B team, Dr. Izhar Zaved, Dr. Anurag Pangrikar, Dr. Sachin Jetlia will be facing Dr. Abhijit Joshi. Dr. Abhijit Joshi, the presenter for today, is from Aurangabad. He is an intensivist and a pediatrician with 20 years of experience and with rheumatology. So, Dr. Abhijit, please unmute and present your case.
Yeah, yes, ma'am.
Dr. Sachin Jetli, I have not seen, I think.
And Dr. Anurag Pangrikar is also. not-
Yes, yes, he's there.
Yeah, they
Yes.
are all there.
Put your camera on, Sachin.
There's a request to everyone, please don't write anything on the chat.
Abhijit. Am I audible?
Yeah, you are very much audible.
Yes.
Okay.
Good evening. Sir, shall I start? No?
Yeah, please start.
So first of all, I greet everybody from the all the coordinators, the experts, the two expert Prajapati sir, Dr. Mahesh Mohite sir, and the guest of honor Dr. Vasant Khalatkar, the participating panels. The panel I am facing, they are renowned academicians, so I am very much happy to present to Dr. Izhar Javid and Dr. Anurag Pangrikar, who are good academicians. So whatever you have a chance to correct myself wherever I have, I may be not good at history taking or good in examination. You can correct my mistakes. So the opportunity is up to you, sir. So shall I start sharing the screen, please?
Yeah, please start.
Is it visible to everybody?
Yes, yes, full screen and you are audible, sir. Yes.
So I am giving the age of the patient, the sex of the patient to start with. So if you are geared up with the case, I will go ahead with the history taking. So in the history taking, so this is an old case. Means I have taken this case 2 years back, and now the patient has grown old. He is now 13 years old, but when we presented, he was 10 years of age, and his date of birth is 24th of October. He's from a rural place of Partur in Jalna district, and he presented for the first time in 21 in February 21, and the history goes like this. He had illness over 1 month. Initially, he had pain in digits of both hands, and there was some swelling, and along with that, there was peeling of skin over the digits, along with itching over the digits. Then, at the same time, he had difficulty in walking due to pain and swelling over both feet. So these are the main complaints. He before coming to us, he was given some medications, and he recovered partially with the medications over 5 days. And the medications were stopped because of the relief, but now he presented with fever, high grade, with chills since 4 days before coming to us, and those were 1 to 2 spikes in the day. And the significant part of the history comes in the form of sudden dimness of vision in the left eye since 1 day. And he also complained of some difficulty in walking, or difficulty due to some tightness in the chest, what he felt that time. But this time he had no pain or swelling of the joints, which he had since 1 month. So this is the short history. Not may not have been taken in detail that time. So you have every opportunity to ask me questions or whatever you feel like. So the history is continued. So you want to ask anything, Dr. Izhar or Dr. These are the presenting complaints.
We just stop here and just ask them to let this slide over and then go for the second slide.
Yeah, basically, we are dealing with a 10-year-old male child who happens to have an illness, which is a slowly progressive disease. Duration of illness initially was 1 month, and it was predominantly affection of small joints of hands and feet. So, duration more than 1 month, along with difficulty in walking and some swelling. So, it appears to be a chronic arthritis, though the duration is 1 month, and subsequently you told that there is history of fever for 4 or 5 days right now when he had come to you. So it is more like a chronic arthritis which is affecting small joints of hands and feet, and then there is associated febrile illness in this child. And the two complaints which are unusual is a sudden diminution of vision since 1 day and difficulty in walking due to tightening of the chest. I don't know, you have to elaborate that history of difficulty in walking due to tightness of chest. Sudden diminution of vision is explained. Probably there is a component of a vascular involvement or vasculitis associated with a joint disease. Though we know that rheumatological diseases are always evolving, so we may not come to any conclusion right now. So it appears more like a juvenile arthritis or juvenile idiopathic arthritis, which is affecting small joints. Large joints, he had not given a proper history. You will see which are more other joints which are involved. And fever is still not of long duration, just 4 to 5 days. So we are not at any conclusion. We have to see whether that fever is going on for another 4 weeks or 6 weeks. So it appears to me that it's a rheumatological disease which is chronic, progressive, and affecting small joints and having a component of vasculitis. I don't know the explanation for difficulty in walking due to chest tightness. I have to just evaluate the detailed history for that.
That was some catching of the breath. Like he used to complain, like he had some catching of the breath.
So you can consider there is a component of serositis there. Catching means you have pleural involvement, you have diminution of vision, that is vascular involvement, and you have already arthritis affecting small joints. So we are on a systemic inflammatory disease. I don't know exactly what is the diagnosis, final diagnosis, but it looks like an evolving disease. So they are evolving. We need to wait for 6 months for them to manifest completely.
Yeah,
so your period is just 1 month.
But he presented catastrophically with the vision loss in the left eye. So we cannot wait till he loses his vision, or so.
Yeah, we have to look for corroborative evidence. We cannot put a diagnosis right now.
Yes.
We have to investigate or look for associated evidences.
So going into the history, there is another.
Just a bit. I just want to take inputs from my other friends, Dr. Pangarikar and Dr. Jetlia, whether their impression is something else.
Yes, we are with the same impression.
Or you want to add anything, or you want to ask anything in particular in the history? Anything is remaining, or shall I just go ahead with the history taking part?
You will be telling us. We will be telling us the detailed history, present illness.
See, the problem is not only pain, swelling, but there is a discommission.
Disformation of the skin over the digits.
Yeah, that let us say, miss, what and all comes with that. We are not say if I sell Kawasaki, that's not usual. I told there is a vasculitis component, there is serositis, and there is a small joint affection. 3 things I am sure. So we'll just club together everything and then decide what it turns out to be.
Yes.
And I forgot to mention there was some rash over the face and over the arm associated with fever, but we thought it might be some rickettsial infection, and it was
your duration has not gone, just 4 days of fever.
Yeah, 4 days.
So
of
that
fever.
rash, nothing means to me at 4 days.
Good.
Yeah. So we asked about the negative history. There was no history of cough or weight loss over. Child was thriving well, had a good appetite. He didn't have any major illness in the past. Birth history was normal. He was born of non-consanguineous marriage, and he was second of the 2 siblings. The elder sibling that time 16 years, now 19 years female now, and there is no history of any major family illness, and he is immunized for age. So as you mentioned, you told about the possible etiology or the system involved, the what would be the pathology or what you are anticipating. So shall I go ahead with the examination or?
Anatomy is multisystemic illness, which appears to be an inflammatory disorder, which is pathology. And etiology will go for history of present illness, and then I'll tell you what will be the possible etiology. You can proceed, Abhijit.
Yes. So these are the examination findings. Child, while presented to us, was afebrile with heart rate of 88, respiratory rate of 20 per minute. He had mild pallor. There was papular rash, as I mentioned, over face and right arm. His anthropometry wise, he was doing well. His weight was 40 kg, between 75th to 95th percentile for his age. Height 141 centimeter, that is also falling between 58th to 75th percentile for his age. There was no icterus cyanosis. There was no significant lymphadenopathy. There was no edema feet. The cardiovascular system was first and second heart sound were normal, no murmur audible. The abdomen was showing no hepatosplenomegaly, though no audible rub, no on auscultation there was hardly anything audible. On chest examination, the air entry was equal on both sides. There was no friction rub or adventitious sounds. So any positive
Is there,
findings?
sir?
This is the time when child presented to us.
Abhijit, stop here.
Yeah.
Let the expert Baldev Prajapati and Mahesh to talk. If they have any questions.
Anurag, you want to ask about anything which is left in the examination, or you find it missing over here, or you want anything in the systemic examination, or along with that some other examination you want me to carry out?
Khadke, are we supposed to make any comment during the case, or will be making at the end of the case?
Mahesh, you can lead some questions so that
There are some questions which you can lead with the history.
What is the pattern is like that if case discussion goes wayward, then experts will intervene. Otherwise, the case is going very well. So we want the why guide it.
I think Dr. Izar,
Wayward, then yes, it is
There
okay.
is power failure. So
Yeah,
yes,
Izar,
Dr. Izar sir is locked up.
He will
Sachin
join
is
back.
also logged out.
So Anurag, you can take the lead now.
Anurag sir.
Yes.
पल्लवी मॅडम, डॉक्टर इजार सर आल्यावर त्यांना लगेच इन करा. आणि आता कोणालाच इन करू नका मीटिंग मध्ये. शानू राहू द्या.
पॉवर कट झाल्यामुळे बहुतेक दोघे गेले ते. सगळीच पॉवर कट झाली.
सचिन आहे
का?
You can wait for a minute or two. They will join back.
but Dr. Anurag can continue, I think.
Yes, please go ahead.
Okay. So one or two important findings I missed in the history. I am putting it in the next slide. So this was the important finding which was not there in that slide. So the blood pressure taken was 128 by 80, and I have drawn the percentiles. So it is corresponding to 95th percentile for both for systolic as well as diastolic blood pressure.
Diastolic.
And the most important part, as in goes from the history, the most important part is P-Gals examination, which I carried out. I might have got some positive findings had the patient come 5 days or 6 days prior, but the patient came at that time when the P-Gals examination was normal.
Unstable here.
And we are now very much used to doing P-Gals examination. I couldn't get a positive finding on P-Gals examination.
Yeah, I think Dr. Izhar is here.
Yes. Dr. Izar, sir, do you want previous slide?
Yeah. Actually, I just want a slide. Actually, electricity connection lapsed.
This you missed.
Yes, sir. Please,
So you
please.
please go through it.
Yeah. You got a hello? Am I audible?
Yeah.
Yes.
Am I audible?
Yeah.
Yes.
Yes, sir.
You got this. You got palar and papular rash or face and right arm. That's the only positive finding in a child who's well grown.
Yes.
Hello.
Yeah.
Yeah, we can hear you.
Yeah. You can proceed for the next slide, sir.
आपने अपना वीडियो बंद किया तो भी चलेगा, ऑडियो.
Yeah, I'll continue with all.
Yeah, these are the blood pressure findings which I have put up now.
Dr. Javed, if you put off your video, your bandwidth will increase. So you can keep audio on and put, yeah, please go ahead. Dr. Anurag, you want to continue, and is Dr. Sachin on the group now?
Yeah, on PGALs, you haven't got anything abnormal, sir.
No.
Abhijit?
Yes. I didn't get anything abnormal.
You got a blood pressure which is.
Yeah, it is on the
95th
95th percentile, both systolic as well as diastolic corresponding to 95th percentile for his age.
Okay. Yeah.
So from now here, how to proceed further?
Yeah, actually very clear that the child had been treated for some point of time with his initial illness of 1 month duration. So we don't know whether they were steroids or something or some analgesic, but for sure that there is no evidence of joint involvement right now. But still, I'll consider initial history to be significant. A small joint of hand and feet involvement, which was there for a period of a month or so. So still, I'm pretty much with part of inflammation of small joint, and your tightness of chest. Probably, I think there is a component of hypertension in this child. It's more than 95th percentile. So still a hypertension which is acquired, it is more because of vasculitis that will be first thing in relation to the rest of the history. It doesn't appears to be a renal involvement because puffiness and all will be the predominant symptom, hematuria, decreased urine output, they are not there. So I'll consider it to be a part of vasculitis. So it's still evolving, but a normal PGALs, I think after 1 month and some treatment, which we know steroids are used A and Y by general practitioners. So I don't know. So still that's in. Probably it had been treated, partially treated.
We also thought in the same way that PGALs, the examination after 1 month of the illness was normal. So we don't know that what child received. We thought of analgesics first, but may have got a short course of steroids. Yes.
You can proceed about the analysis with this. Presently is a systemic inflammatory disease with a predominant small joint affection, skin involvement in the form of papular rash, which is affecting face and upper limb. And there is associated evidence of hypertension, which will tell you me that it's a vasculitis like
Vasculitis.
illness.
Okay. Shall I go ahead?
Yeah, proceed, sir.
Yeah. So we took help of as the child had blindness that was acute onset. So we took help of ophthalmologist to have a look at the fundus of the child, and we got something interesting from them. So his fundus of right eye was normal. Left eye fundus was showing tortuous blood vessel hemorrhages around the disc, macular edema, cherry red spots, optic neuritis with retinitis with subfoveal serous fluid. So this was in left eye.
Yeah, that tortuous blood vessels, it seems like probably is having blood pressure which is raised since pretty long time, but it's not a bilateral illness. So that's something unusual. If you have a bilateral illness, probably I can explain that with hypertension. But even vasculitis can have a vitreal hemorrhage along with evidence of retinitis and tortuous blood vessel.
So,
I'm still not sure
so do
unilateral
you think this
involvement
is
is something unusual.
arteritis etiology or non-arteritis etiology? Arteritis would have given bilateral involvement, or non-arteritis.
Yeah, maybe that's a possibility. We can consider that if you have a systemic hypertension, so more likely to be medium or large size vessels are involved. If I consider retinal vessels, that will go in favor of a small vessel or a medium vessel involvement. So something which is not gelling well. And that too unilateral is again a
Yes,
confusing
yeah,
stuff.
that is unilateral. So, or are we suspecting something locally in the left eye, rather than being generalized for both?
I think apart from a local infection or a trauma,
So as you said, you derived
or probably a vasculitis causing something like a thrombosis
yes.
in a single
So
eye, probably that can
you
explain.
want to stick to that your inference from history taking. Yes.
Yeah, I'm still with vasculitis.
Yes,
I
yes.
have to see why it's a unilateral stuff.
So
Any input from Anurag, sir? Sachin?
Sudden onset unilateral must be some thrombus, because it will not be a sudden onset otherwise.
So are you
Even hypertension will not cause the sudden onset with so much of changes unless it is a long-standing hypertension.
yes, right. So now shall I go ahead with investigations, or you want to give some, as you already mentioned to me that there is vasculitis with some thrombosis component involved, and it is involving the left eye, which is giving rise to the blindness.
If while the patient has taken some medications, is there any history of any medications taken? Is there any investigations done previously for 1 month, the duration of 1 month?
Yeah, investigations were done before coming to us also. So we'll come to that. Investigations were
Details of medications and detail of investigation in last 1 month, before presenting to you.
No, he just took analgesics, as we thought. He took analgesics, but might have received a short course of steroids. Apart from that, he has not received anything.
Or any other investigation that has been done before?
Those investigations are done.
We'll come to that step by step.
We have a chart
No,
of
because it presented with the same.
Yeah, right now we are on vasculitis, which is affecting a medium or large size vessel. That is for sure.
Yes.
Yeah, you can go for, you can proceed, Abhijit.
Yes. Okay. So these are the series of, this is the series of investigations before he came to us, and even after he continued to follow up with us. So these are the serial CBC parameters. you can see hemoglobin, WBC, differential leukocyte count, platelets, ESR, CRP, rheumatoid factor by latex agglutination, urine routine done on 3 occasions, and along with that CPK, serum creatinine, ferritin, that is also there.
You haven't mentioned ESR, which was there on 18th of March. Suddenly your ESR on 15th of February is 90. And what is that in 18th of March?
18th of March.
ESR has not been mentioned.
Sorry.
31.
On
ESR
8th
was,
March 22, 18th of March, yes or not? Sure.
ESR was done because patient came once to us and then followed up after 10 days maybe.
And you told urine protein on 18th of March, it is actually blurred on my screen. Urine protein is how much?
1 plus.
1 plus?
2 plus.
2 plus.
2 plus.
Yeah, 2 plus proteinuria there.
So there is an evidence of ongoing anemia which is progressing.
Yes.
Along with that, if you consider the other cell line involvement, if I see on 18th of March, 18th of March, progressive decrease in WBC count. So you have 2 cell line affection, platelets are not increased or decreased. That is something unusual. If I'm considering a systemic inflammatory response or inflammatory disorder, my platelet should have been very high by now. If it is a duration of almost 2 months or so, HB is going down, that is explainable. You got a positive CRP, which is rising again, going in favor of vasculitis like or inflammatory disorder. Proteins are 2 plus, so
2 plus.
probably I will not put much weight on that unless this is 3 plus or there is associated hematuria RBCs which are seen.
Yeah, we have a protein create spot ratio of 0.62.
Protein create ratio of 0.6.
6, yeah.
That's not significant. So we have got an anemia. There is a decreased WBC count. Most likely, you got a CRP is on a higher side.
Higher side, yes. ESR also on 1 or 2 occasions is on the higher side.
Yeah, but you have to tell me what it is right now. 90 is okay. In all that, 90 is okay. More than 60 inflammatory disease is possible. 90 is okay, but subsequently what happened to that ESR? Because your HB is going down, and if you consider platelets which are also going down.
Yes.
Predominant neutrophils which are on a higher side again goes in favor of a systemic inflammatory disease.
So there is lymphopenia. Do you see lymphopenia?
Oh, I can see the lymphocyte count on the 18th of March.
Yes. Yeah.
How much it is?
18.
18. Okay.
So there is anemia, leukopenia with lymphopenia, and platelets also down.
Yes.
I do expect any inflammatory disorder is going to give that. So we cannot pinpoint anything right now.
You
Request everyone to please mute themselves. Those who are not participating, please mute yourself.
So two out of 3 cell lines, or rather I would say 3 cell lines depleted with raised inflammatory markers, with urine showing microscope proteinuria. So as you said, it is vasculitis. So what are you thinking now?
Sir, we cannot come to any conclusion with this. You can just say that I'm dealing with a systemic inflammatory disease right now. I don't think we can pinpoint any vasculitis with these investigations. They're just supportive.
No, is short? Doctor wants to say that how will you proceed further? Do you want to suggest him to do something?
Yeah. I like him to go for an ANA right now. And markers for inflammation like serum ferritin, you have LDH or D dimers. Yeah, he already did that.
Ferritin is not that raised. Serum LDH is also D dimer assay by that lab parameters is also within normal limits.
Okay. ANA, sir?
Anti-COVID antibodies?
Yeah, that is done. That is negative. So this is what we got in the next follow workup. IgG antibodies to the SARS-CoV-2 were negative. We got the coagulation profile in the form of PT, APTT, IMR, that was also normal. As you said, chances of some embolization. So we got the echocardiography with color Doppler, that was normal. HIV, Australia antigen, anti-HCV, the infections which can give rise to some coagulation problems, they are also not negative. Once we find urine routine normal, in view of the ocular involvement, we thought that we are dealing with some vascular disease, so we got MRI brain with MR angio. It is showing multiple small non-hemorrhagic infarcts in left frontoparietal, left corona radiata, right parieto-occipital, and MR angiogram is unremarkable. Angiogram is normal, but there are multiple non-hemorrhagic infarcts, multiple sites.
Okay. Why did you go for HRCT chest?
Because we didn't get anything in
your chest tightening, you might be explaining with that.
Yeah, so the X-ray chest was like this, so we couldn't get information on that.
Okay.
And, so we got HRCT chest, which is showing left lower lobe pleuropulmonic pathology. So pleura was involved.
So we are still on vasculitis, which is going to explain our HRCT, MRI, which is showing multiple infarct, and clinical symptomatology. We start of a joint involvement, predominantly small joint. So now question is that whether I have a this appears to be, to me it looks like a medium size or large vessel vasculitis with a involvement of lungs and pleura, which is most likely occult rather than a symptomatic pulmonary involvement. I think we are on MAP. You have
so you mean to say it is vasculitis or some systemic inflammatory disease with vasculitis component?
I don't have right now joint involvement. It's more of a vascular involvement. So to me, it's a systemic inflammatory disease with a medium vessel involvement. And MPA will be first possibility because of the involvement of lung. You did p-ANCA and cytoplasmic ANCA?
That we'll come to, yeah, soon we'll come to it. We got it, everything done.
So MPA, it's a polyangiitis like stuff.
So we got the protein C, protein S, antithrombin, lupus anticoagulant, anticardiolipin antibody, both as you asked, anticardiolipin and IgM and IgG are negative. The C3 level 33.7 and C4 is 3.3. And urine spot protein creat ratio is 0.62, that is marginally elevated. And
So
ANA we got by fluorescence, that is 1 in 320. Is it significant?
It's very significant because it's immunofluorescence. You have to tell me the quality, which is speckled or something. If it is speckled and 1:322, it's very significant by immunofluorescence. Along with that, you got you haven't done dsDNA, might have cleared the thing that so.
Once we got this, then we went for further investigation. We got ANA positive by
Can I interrupt, Dr. Abhijit? You have just 5 minutes more because we have 45 minutes per case. Yeah.
So as he has asked about the anti-DS DNA, but along with that we got direct Coombs test, which is 3 plus positive, and anti-DS DNA is positive.
Yeah, you are at lupus, systemic lupus erythematosus. That rash will be explained on that. You have many criteria which are present. You
Yes.
have a pulmonary involvement which is silent there. Your 2 plus albumin has to be considered in urine.
Anemia.
Yeah, anemia is explained on that.
Skin
Now
rash was there.
usually thrombocytopenia is there, but probably it will evolve because as we are seeing platelets were going down, CRP is positive. ESR, again, if it is lupus, probably will not get very high. So direct Coombs test positive.
And
so many of the
serotype.
criteria are filling, and with positive dsDNA, there's no doubt about that. So it's SLE only. Anything else you want to ask?
Yeah, that initially because that male child 10 years, so we don't think of SLE at the outset because we generally do find at this age female preponderance is more. So we got, because of the blindness, we started thinking of the vasculitis component, and then we got all the investigations done. Then because of hypertension, we got everything done. So he was put on this methylprednisolone, then was given induction remission of cyclophosphamide. Then later things planned were like kidney biopsy, then 6 monthly doses of cyclophosphamide, management of BP, and we continued with the steroids, hydroxychloroquine and ecosprin. And we continued with the ophthalmologist, but unfortunately we could not get the vision back for the child because that precious time was lost, because it is said that within 12 hours if you intervene,
Yes, I will.
so we could have saved the eye of that child, so we could not save the vision of the child. This is what is there. Yeah,
Wonderful case. Now expert Gokarna madam, please invite experts to comment on this.
Yeah, yes, yeah.
Abhijit, stop sharing.
Yeah.
yes.
Yes. Thank you very much, Dr. Abhijit, for this very, very interesting case. And thank you, team BEAD. And I welcome the experts. I invite Dr. Baldev to comment and then Dr. Mahesh.
I think, first of all, my best compliments to both the presenter and the person, or the team.
Thank you, sir.
Analyzing. It's a fantastic discussion. Nothing much to add, but I think from the beginning the point was very clear that it is an inflammatory disorder involving the multiple places. Among these, even if you go for the specific aspects, that with the skin rash, age of the child 10 years, joint involvement, particularly it was very clear that probably somebody has treated previously and therefore you didn't get much on examination, but must be probably some elements of arthritis. Second, which I want to highlight the very important point regarding the vision. It is said that broadly I will say that in any case, if there is sudden loss of vision, keep in mind, not particular case I'm talking generally, number one, is there any injury to the occipital region suddenly, sometimes even following the road accident, and over the visual lesion, and even a child may regain. Second, even this type of a sudden loss of vision is in a case of drugs, particularly with the quinine. Now we are not using, but when we are using, we came across several cases. Even chloroquine can cause it, and even vasculitis is known. The sudden loss of vision or even embolic phenomena that can also cause this type of a thing. So I think having all these points in mind, probably with reference to our case, it was highly suggesting that there should be some this type of the condition like vasculitis. very specifically the complaint of the tightness of chest, and even later on what you got on the CT findings, it was classically indicating that the serositis was the presentation. So as a whole, I think if we think without for scare of, I will say, time, I'm go for the summation, that at least way of thinking, way of analysis the case, and way of presentation were really fantastic. It was beyond doubt that if we go for this type of the analysis, as all of us are learning from our, I will say, original source, Dr. Ambedkar sir, that try to think first the anatomy. I think even I will say that slide was important. And then even what type of the pathology. Of course, we may not be able to decide the etiology, we can just guess. And for that reason, we may take the help of investigations, very specific sometimes for the condition, and we may prove or disprove. And in that way, we can go ahead, and most of the times we are able to reach the diagnosis. So I think it was very good, fantastic analysis. The only thing I think in such cases when hypertension is there, blood pressure should be measured in all the 4 limbs. Many a times even a case of the coarctation of aorta or something probably which may be able to diagnose. So in whenever on, if you have doubted some blood pressure problems, I think it should be measured in all the 4 limbs. May not be in this case, but I think next case may be the coarctation of aorta. Thank you very much.
Thank you so much, Dr. Baldev, for your inputs. I invite Dr. Mahesh for his inputs.
I think, first of all, compliments to both the presenter as well as the recipients. Wonderful kind of a discussion. I think Dr. Baldev Prajapati sir has covered most of the points. I'll just briefly go through. In fact, I was writing down the case and making my diagnosis, so I could make it on 4th or 5th slide. I'll just narrate how I approached it. So first, as you correctly said, we had a clearly evolving case over 1 month with a multi-system presentation. Perfect. As Dr. Ambedkar says, the disease going beyond 2 weeks, think infection least likely, other parameters likely. And here you are having multiple presentation, multiple system clearly defined. Then what happened after 1 month? Suddenly deteriorated. So if you're thinking of an immunological or connective tissue disorder, something acute deterioration after 2 or 3 weeks, think of an immunological presentation on that, classical being the macrophage activation. So you had a high grade fever, sudden loss of vision. One thing I wanted some more details on difficulty in walking and tight chest. So difficulty in walking, you could explain on the basis of MRI, which you showed us later on with a multi kind of a non-hemorrhagic infarcts. Otherwise, I wanted some more elaboration on the history of that difficulty in walking. Now, blood pressure was kind of discussed more that is causing those chest lesions and eye. But 128/80 in a 10-year-old child is just above normal. I don't honestly see any reason to present with that symptomatology. Many times 130, 140 is something like a chance recognition. Even if it is acute, 120 won't become symptomatic by and large. That's what my perception is. Dyspnea on exertion, tight chest. I wanted to know whether it was tight chest was dyspnea on exertion or something, so which could have been taken onto a serositis kind of presentation. Urine protein 2+, I think one need to be very careful. That can be anything. You have 0.2 more than 0.2 ratio is significant, more than 0.5 is definitely significant. That's a proteinuria that cannot be neglected straight away. Cherry red spot, again, classically was described for the neurodegenerative depositions. So you need to recheck that particular finding, but unilateral findings in the opthal is definitely not a presentation of a generalized disease like hypertension. So it had to be some kind of a vasculitis or inflammatory part in that. And I think my click was following the investigation which you showed. You serially showed me about 5 CBCs, if I don't mistake. Yes, all of them were on relatively low counts, somewhere between 3 to 8,000. All of them were neutrophilic predominant in that. Almost all of them were low CRP and high ESR. That combination is SLE. Low CRP and high ESR in a 10-year-old child. It is male. In fact, I was February 2020 when I was wondering with this multi-system, are you showing me MISN? Or because that's what was a typical post-COVID period where we had started seeing multiple cases of MISN. I was wondering whether, but then you showed me the rashes, which were atypical, then eye involvement and difficulty in walking, and GI was visibly missing in that. So I thought we are dealing with something else. But this particular combination of low count, progressively dropping hemoglobin with a neutrophilic predominance, with the ESR being high and CRP low, is a very typical scene in a SLE, dermatomyositis, or some kind of lymphoma. So there I almost clicked it. And then later on, you showed when it deteriorated, CRP went high. That was perhaps the features of macrophage activation in the SLE. So I would still be very aggressive and go and do a bone marrow in this child to find out whether the macrophage activation is seen. So that is how I can. As far as vision loss, sir gave the list of it. Maybe I will add one common thing which we recently saw in Wadia, and we rechecked with the literature. Metronidazole is known to cause acute vision loss. We had one child who had come with something else, but found to be some anaerobic infection. And on the round, we were just saying, why is suddenly developing that? And on literature, we found metronidazole is one of the common known features is a sudden visual loss. So my take in this child, don't neglect those subtle changes in the CBC also. In this child, if you're thinking of connective tissue with low count, think seriously about SLE. I know majority they are girl child, but it's not that SLE is not seen in male child, especially in that adolescent period. Yes, that is commonly seen. And this combination, don't forget, I happened to pick up one 5-year-old girl where we were totally lost. And looking back, all the numbers, one thing which we strongly saw is low counts, high ESR, low CRP. I think that combination, be careful. That's a combination typically of SLE. And here you suddenly see a deterioration. The CRP also will go high, which is macrophage activation. So that's where thank you very much.
Thank you for those excellent remarks, Mahesh. Thank you, Dr. Baldev, Dr. Prajapati, Dr. Mahesh, Dr. Abhijit, and Team B.
Thank you.
Khadke sir wants to talk.
Yeah, Dr. Khadke.
I have just 2 points to mention that this was a male child. A female child at this age group gives with this type of presentation, it would have been very easy to say that basically we are dealing with lupus. That is one. So that was abnormal. Secondly, the child had central retinal occlusion, CRA occlusion. That is also very rare in lupus. And the third most important thing which I want to tell all audience is basically any rheumatological conditions, when you have biocytopenia or pancytopenia and inflammatory markers very high, think of lupus, because there is no other condition where you can have biocytopenia or pancytopenia along with inflammatory markers, except basically when we are thinking about HLH or macrophage activation syndrome. Thank you very much.
Dr.
Here the
Pramod wanted to
difference-
say, yeah.
Khadke sir, the difference might be about HLH and macrophage activation syndrome. We have to be very aggressive when we are suspecting macrophage activation, and it may not be having too much of a cytopenia in macrophage activation syndrome like in HLH. It will be just reduction in the cell count in cases of rheumatological condition and if patient is clinically worsening. So macrophage activation syndrome has to be more aggressively suspected and treated. And we may not have the bone marrow as an investigation to confirm it, other than along with the triglyceride and plasma fibrinogen with cytopenias, you may not have the count coming from 18,000 to 9,000 may suffice for macrophage activation along with one of the cell line coming down.
But you don't need a bone marrow to see that macrophage activation.
We don't need bone marrow. That's what I'm saying. Plasma fibrinogen, ferritin and triglyceride may suffice for suspecting macrophage activation syndrome when you have clinically strong suspicion of rheumatological condition. Even in first episode, you may have a patient of rheumatoid condition coming in as a macrophage activation syndrome as a first time presentation. Prajapati sir may add into that, or otherwise
No, I think
the idea was male child. The question was male child at an appropriate age with systemic disorder and vasculitis and going for a central retinal occlusion defect. We have searched the literature and we saw that basically there are very small number of patients of male lupus who are going for CRA occlusion. Anyway, congratulations, both of you. You did extremely well.
Thank you, sir. Thank you.
Excellent learnings from this session.
Let me make a point. The team had asked ANA on the third slide. Dr. Izar had asked about ANA. I noted that. So
Sir,
they had
sir,
come to that.
he's a genius.
Definitely.
He's a genius child from.
Absolutely. Absolutely.
Yes, sir.
Absolutely.
Yes, sir.
Yeah, actually, I was clear with vasculitis, but probably he haven't shown me the last slide ESR. Otherwise, I might have jumped in the ship with lupus only at that time. ESR in the last 18th March slide was absent.
Yeah. So with this, we go on to our second case. Is Neha there? Dr. Neha? Okay, I think Dr. Neha will log in soon, and I have the pleasure of introducing our next presenter, who is the Secretary of IAP Palghar, who's also my very good friend, who is Dr. Vaibhavi Barot, and she is going to present the second case, and to accept this challenge will be the Jalgaon team, and the participants are Dr. Avinash Bhosle, Dr. Rahul Patil, and Dr. Gajanan Surewad. So with this, I invite Dr. Vaibhavi to present her.
Good evening, everyone, and thank you, madam, for such a sweet introduction. And I, at the outset, I thank Maharashtra IIP for giving me an opportunity to present the case in this MAHAIP challenge. And I also thank Dr. Pramod Kulkarni for guiding me during the case, during my case.
Yeah, go ahead.
Yeah. My case is a 4-year-old boy, third by birth order, born out of third-degree consanguineous marriage, resident of Vaitarna, Hindu by religion, Adivasi community, presented in OPD with history of fever since 4 days, cough since 2 to 3 days, breathlessness since 2 days, and he had vomiting, which was mainly post-tussive. There was poor oral intake. The child was lethargic and fatigued. So here we have a child with fever, cough, and breathlessness with a poor oral intake. So I would ask the team, what are your thoughts on this history taking?
Yes, sir. So the symptomatology is the acute onset in origin, looks like in infective origin, and child is breathless. So like he is having the going to the respiratory failure, and there is a component of dehydration is also there. So see the acute onset of infectious etiology, which has been developing complications like respiratory distress and dehydration. We'll like to know the immunization status of the child, and that was, and being from the Adivasi community again. Okay, we'll keep it that mind. Yeah.
Regarding the additional history, like there is a history of just fever for 4 days, so it's acute in onset, and there is a cough, breathlessness, so respiratory involvement basically. There is also airway involvement is also there. At the same time, there is poor oral intake and lethargic. So there is an additional systemic component. So more likely bacterial in origin. We'll have to keep it in mind in this child.
Okay.
Another important thing, yes, ma'am. Another important thing is how is the fever, whether it's a very high.
Yeah, I'll come to that. Yeah. Okay.
And another one I wanted to know is regarding the history of breathlessness, ma'am. Is it
yes, sir. Yeah.
Is it a sudden onset breathlessness? The parents have noticed that increased respiratory activity over, sudden onset because 4-year child. So it's unlikely to be foreign body at this point of time because fever is, before this breathlessness. But I will keep in that one mind, the breathlessness and cough. Child is having cough since 3 days, but post vomiting, vomiting is there. It means that I feel the cough is very severe. So anything upper airway, inflammation or something that we will keep in mind in that way, because child have poor oral intake, and in the extent of lethargy and fatigability, I mean to say that the upper airway somewhere there is the inflammation so severe, some membrane or something that at this point of time, so that child is having such a poor oral intake. So I will consider this is a very sick child at this point of time. And consanguinity and we will evaluate further. Is there any further view? Then we will talk about the community as well as the consanguinity.
Okay, yeah, very nice. Yeah. So the fever was high grade, not associated with chills and rigors. It subsided on antipyretics. Child was lethargic in the interfebrile period. The cough was dry in nature, in bouts, and was associated with post-tussive vomiting. Child developed breathlessness, his oral intake decreased, and child became lethargic. Now, in the past history, child had similar episode of cough and breathlessness, treated by a local GP, was given some IV fluid, some IV antibiotics, and was given nebulization. The child got better with that. In the present illness, he was again taken to the same GP, but in view of lethargy, was referred to a hospital on 20th of June. So the same thing, or you would like to add anything?
Yeah. So again, like we will like it most it looks like an infection. There has been previous episodes and they have got better with some antibiotics. And the lethargy part here look like due to the breathlessness, he may be developing the hypoxia and dehydration. Both of these components may are contributing to the lethargy, and he may be having the shock or impending shock like presentation there. Yeah, so that
in the past history you mentioned about cough and breathlessness recurrent episodes. So how
only once
only once he had
1 year back. Yeah.
1 year back. Okay.
Yeah.
And how is the like he's thriving well or yeah?
Yes. And he's okay, Adivasi community, so we expect a little
his
malnutrition.
His immunization status and his nutritional status.
Okay, sir. And would you like to ask any of the negative history? Something you want to know?
Of like similar illness in the other siblings or other in their area, locality area, like communicable disease we are talking about.
Okay, no history of any person in the neighborhood suffering from same thing, and the siblings are also okay. He's the third child. Yeah.
Any history of who is there for doing cough?
No.
It's not there.
Okay.
Okay. Yeah. So negative history, there is no history of any allergies or family history of asthma, no history of repeated nebulizations. There is no history of COX or COX contact. Immunization history, his routine immunization is completed till his age. Developmental history is normal for his age, and dietary history consumes only rice and potato. So from this history, what is the provisional diagnosis?
It is a acute onset respiratory tract infection, mainly involving the airway. Looks like to be bacterial origin and having complications like maybe hypoxia and respiratory distress and dehydration.
Very good. Yeah. So basically, we are dealing with the respiratory system, right?
Yes.
Yes.
Okay. Now on examination, the child had a fever of 100 degrees Fahrenheit. Heart rate was 142 per minute with a respiratory rate of 56 per minute. The saturation on room air was 97%. Pallor was present. On systemic examination, on respiratory examination, the trachea is central. The air entry was bilaterally equal. Subcostal retractions were present. Intercostal retractions were present. Bilateral creps are present. Bronchi is present. CVS examination, S1, S2 normal. There was no murmur, no gallop. CNS, the child is little lethargic. The reflexes are normal. Per abdominal examination, it is soft, liver of 4 centimeters and spleen of 2 centimeters. Anything else you want to add?
Lymph
or ask?
Lymph nodes?
No lymph nodes palpable.
Okay. Any throat examination? How is the throat examination?
Throat is normal.
Okay.
And we take him as a very sick child, like appearance it's not mentioned, but we take as a sick, very sick.
Yeah, he's lethargic basically.
Yeah. So
okay,
respiratory, yeah, he's having respiratory distress, he's having anemia, and organomegaly is also there.
So
Yeah.
Splenomegaly.
Bilateral crepitations and wheezing. It's a sign like both airway, small airway and parenchymal involvement is also there. Additional, there is a retraction. So bilateral lung involvement. Additional, there is a hepatosplenomegaly. So that is one thing we'll have to keep it in mind.
And alveolar.
Then it looks like more of because calorie is there. So anemia, whether it's associated with like any hemolytic anemia, there is chances for certain communities in Adivasi and tribal belt.
Any conjunctival redness, madam? Eyes?
No conjunctival redness.
Okay.
Okay.
So
Very
we-
good.
Yeah, it's a again respiratory. The pathology looks like to be at the alveolar level because he's having the
Yes.
tachypneic crepitations.
So basically respiratory pathology. So yeah, what are your differentials now? Can you elaborate your diagnosis?
Now considering atypicality, like pneumococcal, we say there is a pneumonia, less of cough, more of a fever, tachypnea, unlikely. A small airway plus parenchymal involvement in addition to liver and spleen, and additional cough as a major component with breathlessness. Mycoplasma is one possibility, school going child. So
Yes, very good.
That is one possibility.
Yes. Okay, yeah. So what after coming down to differentials, what investigations you will ask for?
General and specific investigation. Among general, like hemogram, we see CRP and chest X-ray. To be specific, we want to see the, and in addition, considering the etiological diagnosis.
What will you get on chest X-ray? What we expect since it's a respiratory pathology?
Hyperexpansion with bilateral diffuse opacities. Most likely that is what we will see. We may not be able to see any local cause because the auscultatory findings are bilateral.
Yeah, absolutely.
Mycoplasma axiom, we want to add. Yes. Exactly.
So this was the chest X-ray. Can you comment on the X-ray?
It's a
bilaterally well exposed bilateral parenchyma looks to be okay, as there is no major patches in the periphery, but left paracardiac area there is some haziness, left retrocardiac there is some haziness, mostly prominent bronchovascular markings are there. The angles are also very clear. There is no trachea is there midline.
Yeah. So basically X-ray is normal type. Yeah.
Normal.
Okay. Now CBC. CBC hemoglobin of 6.2, RBC count of 2.6, the total count of 7,800 with neutros of 58 and lymphos of 33, MCV 73.46, MCH 23, RDW is 19.1, CRP is 35, OTPT is 92 and 64, urine routine only 4 to 5 pus cells. So what do you infer from this CBC and X-ray chest?
There is a severe anemia, madam. HB is low, so severe anemia. Right. RBC count is low. That is strange. WBC counts are like non-specific. To say like no leukopenia or leukocytosis, but ratio is also not that abnormal. Grossly polymorphic or lymphocytic, so non-conclusive actually. MCV. Considering the age like 73 MCV at this age, it's unlikely nutritional. So there has to be some other cause we'll have to find out. MCH is borderline low. If you consider iron deficiency at this, all three will be significantly low. But MCV is normal at this point of time. So we'll have to take it in that consideration. In addition, there is a spleen. So we may not get spleen per se because of illness. It might be anemia, splenomegaly, maybe pre-existing. That also we'll have to keep it in mind. RDW is raised and CRP is high. So infection is there, mostly bacterial infection. SGOT more than SGPT. So non-localizing infection, non-hepatic cause, but there is some liver involvement. Some liver, maybe further evaluation, disease may progress. So we'll have to keep check on the worsening or improving liver function. Urine protein.
So what further investigations would you like to do after getting this CBC?
We want one peripheral smear, ma'am.
Retic count.
Retic count peripheral smear. That is,
yes.
If you get that one, that we will have some idea. Means we have possibility of whether it's
Effective erythropoiesis or not.
that is
Okay.
answered in hemoglobinopathy.
Mycoplasma IgM, madam, because hemolysis is known in infection, mycoplasma infection, that is one there. Considering the pre-existing anemia and splenomegaly, we'll have to rule out the hemolytic cause for the anemia also. So we'll see the smear for RBC lysis, reticulocyte count,
And blood culture.
blood culture.
And you,
Okay. Yeah.
urine routine microscopy only pulses, no protein.
4 to 5 passes. No protein, nothing else. Yeah.
Anthropometry, I think we have not seen anthropometry mostly. I think in the history, we wrote this.
Weight wise is less than the third percentile.
Okay. Okay.
Yeah.
And there is no edema.
Okay. No.
Okay.
Another specific, ma'am, if you get peripheral smear, then we want one to rule out the hemoglobinopathies also. That is the one thing. Tribal community,
Okay, yeah.
with anemia. So hemoglobinopathy is the one thing we need to keep in mind, even though sickle and others also may be the possibility. Thalassemia.
Yeah. So we have sent the peripheral smear. In the meantime, the treatment was started with IV fluids, IV antibiotics, and nebulization 4 hourly. On day 2, the child had continuous fever spikes. The cough bouts increased. Tachypnea and distress increased. So what now? Okay, you want day 2 investigations were repeated in view of the increased cough bounds and tachypnea. Investigations were not much of significance, same as day 1. And till then we got the peripheral smear, which shows Howell-Jolly bodies, sickle cells, teardrop cells, hypo and aniso microcytosis.
So there is evidence of hemolysis in the smear. So there is pre-existing some hemolytic anemia, mostly considering the sickle cell. So sickle cell anemia. In addition, there is a top of this is acute bacterial infection with progressive respiratory worsening.
And one more thing, child is, as you told, his weight is less than third centile. Probably it's anemia might be the chronic thing. That might be the cause for his failure to thrive also. If you go further for evaluation.
Nutritionally, he is definitely very less.
Only light and
He is eating. That's why there is mostly wasting and stunting will be correlating with the nutritional deficiency, malnutrition.
Hello. Hello. Hello.
Yes, you are audible.
आवाज येतोय तुझा हा
Yes,
yes
sir.
you're audible.
Okay. Madam, wait, madam.
Vaibhavi, go ahead.
Madam, त्याची स्क्रीन फ्रीज झाली बहुतेक.
हा स्क्रीन फ्रीज झाली बरोबर. I think she is there but
I think she has left.
I think her connection is
ha,
lost.
yes she is not there.
Yeah.
So Baldev sir please
I call him.
you call her.
Baldev sir, till then we want.
Okay. Yeah, sure. I think again, very interesting presentation, and even the analysis
He
fantastic.
came back.
Sometimes I have seen that even the postgraduates are not able to do the way in which even the senior practitioners are doing. And that's a good that even they have not forgotten this art of this clinical analysis. I'm sure, I think that part is to be appreciated. I think if we simply start the story, that 4-year-old boy, third-degree consecutive marriage, we should not forget. There's some disorders always we have to keep in mind. But the main presentation was fever, cough, and breathlessness. We know that by WHO definition, we'll consider that it is lower respiratory, likely some pneumonia. But we see many patients of pneumonia, even sometimes see serious problems, but they don't present so badly as already described, that decreased oral intake and lethargy. And I think broadly I will discuss, not pertaining to that case, but any child is having this type of the lethargy or decreased oral intake or remaining, I will say, decreased activity younger the child, we'll have to mainly check the 3-4 points. Number one, is it anemia, which is the most common? And you know, our children, some degree of anemia is very common. And if it is significant with the illness, always they present with this type of presentation. Second, we'll have to check it. Is there any problem of perfusion? I think even due to any reason, if there decreased perfusion, these non-specific manifestations like lethargic, decreased activity, decreased oral intake develop. And third, always we'll have to check for the oxygenation. And I'm sure that most of the children will be able to get it. And of course, we should check even the glucose and electrolytes occasionally. These when the patients are deteriorating. So I think here it is very obvious in this region that besides the lower respiratory infection, anemia was the major component. And probably that may be the reason for this lethargic and other things. With the fever, we have considered infection, but at the same time, I think they stated very rightly that the child was even lethargic or decreased activity during the interfebrile period. Then of course, we'll consider some bacterial infection. And with that, if we consider this infection, even past, I think 1 month back or sometime back, child had the similar some problem, must be mild. Some general practitioner could manage probably with some drugs and fluids. But of course, that means the child is vulnerable to develop these repeated infections. This much at least we can interpret. If it is so, we'll have to keep in mind that what condition is making the child vulnerable to develop these repeated infections. Very commonly, I will consider even malnutrition. That always we should check. Somehow, I think in spite of the good history, I'm not sure whether I have missed or not mentioned regarding the anthropometry of the child, and the growth charts are lacking. I think that will give us the exact nutritional status and growth of the child, which is very important, I will say, in any child, whatever the condition. Very simple, even the outdoor patient, but always we'll have to look for. Probably what they have not complained, you may get in the growth chart. So I think that is very, very important that that we should mention. And for this reason, maybe the malnutrition 4 years old child, particularly I will say when the child is from the tribal community, malnutrition is more problem. So that we can keep in mind. If it is not say, some basic condition like sickle cell or even primary immunodeficiency disorder, even HIV we should keep in mind. And these children will present with this recurrent even pneumonia or recurrent infections. So I think these are the things which we should keep in mind. Now coming to this presentation, when the child is presented with lower respiratory infection, likely with signs, but very prominent complaint was cough and count and other things. Later on we see even the chest X-ray not suggesting the very specific consolidation. And in that case, mimicking like pneumonia, but we don't get this evidence of pneumonia, or even CBC does not indicating this bacterial origin. Always we have to keep in mind the two things. Either this some viral, and that can be with the H1N1, but with this repeated this the story, I think mycoplasma becomes a very strong possibility, which we should keep in mind. And that can present, mycoplasma, as it is said, the walking pneumonia, every patient is not walking. Even mycoplasma is known for the complications, and that even systemic involvement is known. It can cause even the jaundice, it can cause even this CNS involvement. So this dissemination or this multisystem involvement in mycoplasma, in severe mycoplasma, should be kept in mind. And that can cause even the hepatomegaly, splenomegaly, some mild enzymatic reaction, and even the, I think here not done, but the Coombs test if you do, that may help you. Or even the requires, even you can go for the cold agglutination test. I'm not sure, probably this is not completed, but later on they might have gone for the specific investigations. But the point is, I think besides, with even this sickle, suppose if you have got it, you know that it's this child is always vulnerable to develop these polysaccharide infections, organisms, particularly streptococcal pneumonia, which may even prove to be the fatal. Again, immunization status of the child is very important in details. Probably that is not mentioned, but we should go the details that which very specific vaccines are given. not just given for the age. Because if you go whether the streptococcal, the pneumococcal vaccines are given or not, even another H influenza B also, I'm not sure. Because these infections are common in this type of the children. And many, even sometimes, it may go for even the fatal infection. So that we should keep in mind. I think Krebs and bronchi, but X-ray is not showing any specific opacity or so. Again, it favors either the viral or mycoplasma. I think here, probably to me, it is more suggesting of even the mycoplasma or even with the sickle due to the immunocompromised status, some bacterial infection. And I think here, blood culture is important. Routinely, we don't go for the blood culture in respiratory infections or pneumonias, but I think in such patient we should go for the blood culture, which may even help and which may guide even for the further or the future management. I think at this juncture, these are the points coming to my mind. I think further probably workup may reveal exactly what was the situation with this patient.
Yes.
Dr. Vaibhavi?
Yes, Dr. Vaibhavi, you can proceed.
Hello,
Dr. Vaibhavi?
Is she here?
Yeah, she's there. Vaibhavi, can you continue? I think she's having problems. Dr. Shailesh, Vaibhavi, unmute and start.
I'll call her up and tell her to join.
She's joined. She's there. But
Yes, ma'am. Please call. Joshi, ma'am, please call her.
Vaibhavi, can you
Shailesh, I can
ask
see.
Vaibhavi to continue?
Yeah, otherwise see.
Pallavi ma'am, Vaibhavi ma'am can unmute herself, yes? Yes, ma'am. Yes, ma'am. She's
Vaibhavi,
She can unmute herself. Vaibhavi ma'am, kindly unmute yourself.
She's joining. I called her.
Yeah, ma'am. Thank you.
I think the rains have caused havoc everywhere and there is network issue. At least Vasai was flooded. Mahesh, you would like to add something to the discussion?
Just couple of points. I think sir has given an extensive elaboration of the whole things. As he said, third-degree consanguinity, Adivasi child. I think Dr. Abrekar sir, whenever you get this kind of a case, always would ask first question: was the child absolutely all right prior to the problem? And you would get many answers to that. Whether he had a similar episode in the past, whether he had some kind of thromboembolic phenomenon, whether he had any kind of minor major problem, but basically PM child, whether he was always active as ever. So that could give you a clue whether this is acute on chronic or an acute present. Probably what you described ultimately is acute on chronic rather than an acute problem. This is a typical case wherein you sometimes may kind of neglect the chronic problem and get on only with respiratory pathology. Though you initially presented as a progressive respiratory disorder getting into respiratory failure. So typically you gave a respiratory infection which went into respiratory failure. But if you see the numbers, this child was tachypneic, had severe retractions, he was lethargic, but at room air its saturation was 97%. That's not a parenchymal disease for sure. That is almost not an airway disease also giving rise to the lethargy. So there are some other reasons for the lethargy, not just hypoxia, maybe hypercarbia at times, being a respiratory airway disease. So I don't feel this was a respiratory failure because that room air saturation was well maintained. So you have to find out, and subsequently on the X-ray also didn't see much, except I noticed that the 9th rib expansion was there. So slightly hyperinflated X-ray. Now with that, I also want to know what is the consistency of that liver especially. So at times, if you have a tachypneic child with a hyperinflated chest, you get a liver and spleen getting pushed down. So how to know whether it is acute liver or chronic liver or kind of push down liver or chronic liver? Perhaps a consistency of the liver will tell you that. It's a soft rounded liver, nice soft liver without any tenderness, something. It could be just transiently pushed down liver and you examine the patient after recovery and both the things are gone. So consistency of the liver is something which I definitely want to know from this. Third, on the mycoplasma, we had a good discussion. age 4 years, even by the literature, is just kind of a lower end of normalcy. Generally, we would consider mycoplasma beyond 5 years, not before that. But yes, you can get it even at the age. But I would consider that being slightly odd age, a bit too early. Mycoplasma, by up to date, 25% mycoplasma infections have extra pulmonary manifestations. So it can cause literally everything, as Dr. Baldev Prajapati said, including CNS, the renal, we have seen one of the markers on the CBC or hemolysis of mycoplasma. If you get a MCH high more than 38, you think of that. That is typically you will get in kind of a hemolytic anemia, typically with mycoplasma, which is kind of a autoimmune, equivalent to autoimmune hemolysis. So you get an anemic child with a MCH high, think of mycoplasma on the background of this respiratory condition. The hemoglobin low 6.5 with a normal MCV with this malnourished child from Adivasi belt, don't forget a possibility of dimorphic anemia. It could be iron deficiency along with a B12 deficiency, which can always fool you. And there perhaps further iron studies can help you. But he had organomegaly, which was going against a clear nutritional anemia. But one can always have organomegaly due to some other disease and add on the nutritional anemia. So that alone cannot remove everything. I suppose I have given everything that I have written here. Yeah, just to reiterate, was it an absolutely normal child? And third degree consanguinity, as Dr. Baldev Prajapati said. The whole picture was not coming into, whenever you can't fit everything into one picture, like only 4 days disease coming with such a large liver and spleen is a bit difficult to explain. So obviously that liver and spleen either is pushed down or it is a pre-existing for a long time. So that's how you can grossly approach it. That's how one gets.
Sir, one
Thank
more
you.
thing one more thing I want to ask. Like this child is only on potato and rice diet. Considering organomegaly wasting, whether he was advised by somebody to give only potato and rice, and maybe he is having considering the consanguinity with some storage disorder or metabolic problem. So was it like this Adivasi, even though Adivasi they have so many plenty of stuff to eat, but why they are eating only potato and rice? That was specifically mentioned in history. So is there like something somebody considering metabolic problem told them to give only carb diet and avoid rest of the stuff? So that is one possibility, like storage disorder with anemia.
Well, perhaps they don't have option.
Maybe.
Yeah,
I think Dr. Baldev wants to say something.
Sir wants to add.
Just I wanted to clarify that in any chronic respiratory distress, there may be the I will say the push down liver, but not the spleen. If the spleen is palpable, always consider that that is definitely involved due to some disease process. The reason is, you know, that once it becomes palpable, it becomes the 2 to 3 times enlarged. And second, even this push down effect to the spleen, if at all, it is very minimal. Liver is known, but not the spleen. And therefore here, if the liver and spleen both, if you put together, I would like to consider that definitely whatever may be the reason, but it should be due to the organomegaly. And second, mycoplasma, of course, commonly our traditional teaching that consider after the age of 5 years, but even 2 years, 3 years, mycoplasma has been reported. So that should be always kept in mind. And third point, as such, I'm little bit at discomfort, the lack of anthropometry of the child and the growth chart. Because probably, as Dr. Mahesh said, I agree with him, we do not have the exact information that what was the nutritional status of the child, what may be the even immunological status of the child, or even growth of the child. And I'm sure that this information should never be missed in any patient. Thank you very much.
Dr. Vaibhavi, I think she's joined. Neha, you'd like to continue?
Yeah, Dr. Vaibhavi, please.
Yes. So I think we were at the peripheral smear, and I missed all the discussion. But the peripheral smear showed Howell-Jolly bodies and teardrops and sickle cell. So I think the discussion is what next, like after the peripheral smear. The HBEPP was sent, but what is it? what is the diagnosis now?
Ma'am, already we discussed like acute on chronic disease, some respiratory infection, with some systemic pathology, with some pre-existing anemia, mostly additional nutritional deficiencies, like maybe malnutrition, not maybe, there is malnutrition also, severe acute malnutrition. These are the maybe thing, immunodeficiency. So we'll have to work out for all these things like hemoglobin electrophoresis, iron B12 levels.
Okay. Yeah, but seeing in the view, the child had fever, cough, breathlessness, and the peripheral smear which you asked sickle cell. So do you think some relation between the respiratory system and the sickle cell? Any correlation?
Infections maybe sickle cell, sickle anemia. These patients can have acute chest syndrome, sickling crisis, but they you may not get this fever and cough in sickling crisis, chest syndrome. Actually, their patient is actually breathless.
But there is another more important thing. There is no bone pain in all those history was given, ma'am, in this case. And second is that sickling. We will do a simple sickling test also for that. I think sickle cell is a chronic process is going on where this respiratory pathology has been imposed. Sickle cell crisis.
So there is a dilemma whether it is LRTI or an acute chest syndrome. So what is your take on this?
No, it's not a LRTI because chest X-ray is absolutely fine if you say LRTI also. So we cannot X-ray definitely the giving all the clue to us. So it's not a diagnosis of exclusion, but it looks like a acute chest syndrome rather than the LRTI to us as of now. Because we had seen at the end of discussion and the X-ray other investigation. So we need some few handful investigation. Like ma'am told already, HB electrophoresis has been sent. So diagnosis will come. But sickling test, simple sickling test, that's what we want. And it probably the acute chest syndrome presented because of sickle cell, underlying sickle cell disease.
So now what is the diagnosis?
There is no specific test we can say, ma'am, this is like acute chest syndrome. So you need to treat it like maybe just PCV transfusion. After that only we'll come to know how is it this thing.
Very good.
Condition.
And another one more thing, ma'am, that we need to assess the another two siblings of that patient child, the parents also, you know, their spleen. We want to know the spleen, splenohepatomegaly for those children also. We will assess the family also for that thing. And if turn positive, then we'll go ahead with a blood investigation for them.
My screen is locked. Just a minute. Okay, so whatever. So this was an acute chest syndrome patient. So what we were initially thinking like LRTI, and now patient is treated as acute chest syndrome. The patient, as you rightly said, was given packed cell transfusion, and the overnight after giving the packed cell transfusion, the child in the morning recovered suddenly. There was less of cough, and the distress also subsided. So if it would have been an LRTI case, it wouldn't have been so drastic improvement. So our case is a case of sickle cell crisis in the form of acute chest syndrome. And HB EPP we got, which showed signs of sickle cell disease with a hemoglobin S component of 70.3%. The other two kids were worked up. Since being a lower socio-economic class, the parents refused for workup, but somehow we convinced the parents to do at least the children's workup. out of which one child is absolutely normal and the other child is carrier, and this is the affected child.
Vaibhavi, stop sharing.
Sorry for intermittent disconnection. Yeah.
Very good case.
Yeah, excellent case. Dr. Baldev, you would like to comment on this? And
I think somehow I am coming from the area where sickle cell is not common. But I remember that I always, whenever go to the Baroda for exam, there will be plenty of patients of sickle they were keeping. And I used to tell them that I'm coming over here to learn the sickle. And all the varieties of sickle, we used to go because Rajpipla, Chota Udaipur, these are the areas nearby Baroda, and some of the tribal communities nearby Vapi and Gyara and nearby Surat in the south Gujarat, where the sickle is very common. But the sickle is known even to present with these various presentation. I think this may be the acute chest syndrome of mild. Otherwise, most of the times it is always life-threatening and very critical situation. Unless we manage in time, it becomes very difficult to face it. Of course, I hope that the other vaccines must have been completed, because this is very important aspect, many times missed even by most of my residents to advise them. I think in the practice we should see, because all of us know that particularly the polysaccharide vaccines are very, very important. And all of us are now aware that government of India has taken this sickle cell issue very seriously. They have, with the help of some Delhi people and Dr. Anupama Satdev, they have even started this to work at how best we can. And even as usual, you know, our Prime Minister, he wants that even the sickle should be removed from this country earliest. He has given some target also. Of course, I think if we understand the details, if we diagnose here, as Madam said very appropriately, that we'll have to see even the screen the other children also, or other members also, so that we can pick up them, we can guide them, and even the counseling is also very, very important for future prevention of the transmission of the disease in the future generations. So I think these are the very important steps which all of us know as a pediatrician and we should try. But again, if I re-emphasize, Madam Dr. Vaibhav, I think your contact was lost due to some technical issue, but we were in search of this nutritional status of the child and even the growth chart, but somehow we didn't get it. And I'm sure that next time probably we'll get the more details of it, and it is very important every child. Sorry for re-emphasizing 2-3 times, but I think this is the thing which
I forgot to put the slide anthropometry. The weight was 10 kgs, which was less than the third percentile, and the height was also less than the third percentile. I think I skipped the slide. Sorry, sir. Yeah.
And as all of us know and learning from Amlekar, so that suppose if you have the multiple findings and if you put on the growth chart, even we will realize that when the baby started to faltering and when the problem started regarding the nutrition and other issues. And I'm sure that these children with the nutritionally bad and immunologically compromised, all these problems are more. They manifest even seriously, which probably other children you may be treat as an outdoor, but these patients are always problematic, as all of us are aware of it. Thank you very much. I think this is from my side.
Excellent, team Jalgaon, and I invite Mahesh to make his comments.
I think I already said what I wanted to. Just maybe a typical book picture sickle, perhaps we don't see in our part of the country, wherein typically described is autosplenectomy after 5 to 7 years. But on our side, I am yet to see a child who is having no spleen. On the contrary, as they grow, the spleen keeps on growing further. And this typical child with a larger spleen showing whole jolly bodies, that's a kind of a functional autosplenectomy, which is already established by age of 4 years. We, on our side, we do see sickle thal combination. There are two typical belts in Raigad district. Also, got Adivasi belt, Karjat area, wherein we see a lot of sickle children, and they're all with a large spleens. We hardly see any autosplenectomy. Again, the sickle chest syndrome per se, I have seen about 4 or 5 cases, but they were in a later age group. 4 years is a bit too early that we would think of. So that's a bit unusual that I have seen, but a very wonderful case. At least you could think that this could be a sickle chest syndrome. Otherwise, at that age, many of us may not think of. And presently, the episode of bronchiolitis going so high, and being a malnourished child can easily be kind of mistaken as a bronchiolitis child. Though he started spiking on day 4 and day 5, that's a bit unusual with any kind of bronchiolitis. But I think overall it was a wonderful case to good learning points coming out of it.
Sir, we also
rest, I
have
think we
seen
already said
sickle
this.
for the first time. It is not common in our belt. So we
Yeah.
have presented the case. It is the first sickle in our area. We have seen many sickles in Dhanu area, but not in Vasai Virar area. It is the
Especially if you're
first
not seeing them,
update.
then your pathologist, many times your pathologist has to be very smart to pick up those rare ones because they must be
Yes,
seeing
sir.
much less.
It was
So
basically
this was
after, yeah, sir. It was basically after the peripheral smear report, which said the
Yes, sir.
sickle cell, and then it clicked us because nothing was fitting into the fever, cough, breathlessness, the liver, spleen. So after seeing the peripheral smear, that also took a bit time because they were searching, and then sickle cell, and then it clicked us that it could it be sickle cell crisis, and then we took opinion of our hemat doctor Amit Jain. And he said, yes, it is sickle cell crisis. And then according to his advice, we did the further treatment.
just one more point to make here. As a management part, in a sickle crisis of any kind, many times we'll end up doing blood exchange rather than a Paxil transfusion. These are the patients who are chronically anemic and already in a compromised state. So when you are dealing with giving Paxil, first of all, it's not required in most of the sickle crisis, but if it is required, then what is recommended is to do the blood exchange. Paxil exchange, that's like an exchange transfusion in the bigger child many times. So you'll end up giving 3 or 4 packs as we do in neonatal exchange transfusion. Here, ideal recommendation is to give exchange transfusion. And once he goes through this sickle crisis or kind of a moya like crisis or hemiparesis or something, then we are supposed to maintain the HbS below 30% so that they don't land up again. And for that, electively, again, you need to give exchange transfusion whenever the patient comes with this kind of crisis. So plain Paxil at times can be causing more catastrophe.
No, sir. Sorry, sir, but according to the recommendations, I'm not able to share the slide. In people with sickle cell anemia, give simple blood transfusion, that is 10 ml per kg, to improve oxygen carrying capacity to people with symptomatic ACS, acute chest syndrome. And in people with sickle cell, does it perform urgent exchange transfusion only if the oxygen saturation is below the 90th percentile, and then give supplemental oxygen and exchange transfusion. This is the newer recommendations for the sickle cell disease. So that's why we had just given a packed cell transfusion with 10 ml per kg, and the child had recovered. So that's why we didn't go in for an exchange transfusion, sir. So sorry,
Yes,
sir, because of the internet, all the things have been messed up.
No,
But,
I think it's true that all the patients may not be submitted for the exchange, but most of the patients can be managed by simple PCV, even
Absolutely.
crisis. But when the sickle cells are in higher number, I don't remember the exact percentage of the guidelines, but when they are very high number, probably by giving the simple PCV, we may not be able to manage. In that case, we'll have to go for the, because sickle we'll have to remove. Unless they are very highly concentrated, then your PCV may not work. But I think very few patients may require the exchange. Most of the patients we can manage by the PCV.
This time maybe the patient was presented in very severe distress and lethargy, because if we see the history 1 year back, also he had the same thing. But at that time, unknowingly, the GP had given him IV fluids, like always they do IV fluids and IV, because of the restoration of hydration and antibiotics, what is the mainstay treatment for acute chest, he had recovered it. But at that time, it was not investigated. And this is the second time when he again got a relapse of acute chest syndrome. And that's why maybe the child is more bad and more lethargic and more breathlessness. And that's why he was transferred to us.
Even many a times these children are prone to develop these infections. Infections are very common in the children, and that too particularly polysaccharide and even the salmonella. And that's why even they may present with this sepsis also. Simply offering the IV fluid and antibiotics may be sufficient even to manage if you are not diagnosed or if you don't know. But very important component, and that infection may be the killer in these patients. Therefore, once we have diagnosed, the vaccines are the best protector and earliest given the antibiotics. Usually we say that avoid the antibiotics unless you have diagnosed, but here consider that it is the immunocompromised status, and therefore earliest the antibiotic should be offered, keeping in mind the organism salmonella and the polysaccharides.
Yes.
Sir, these cases, I have seen 3 cases of presenting as a acute paraparesis, sickling. And one child is now 22 years, completed engineering. And we have to think of doing hydroxyurea, which is the standard of care to prevent all the sickling crisis in future. So once we have diagnosed sickle cell anemia or crisis, give hydroxyurea to them. And all these vaso-occlusive crisis or acute chest syndrome, correction of acidosis is important by the time you give an hydration before you give the blood transfusion. And as was rightly said, and even the presentation in our country and in African countries is different. Where there is acute chest syndrome is more common. In our condition, it is comparatively less common, and it is more of this bone manifestation, asymptomatic avascular necrosis of femoral neck head. That is quite common, and patient usually present with that. And I had 3 patients, and after giving hydroxyurea for nearly last 18 years, second child is now 19 years, and third is 17 years. All the 3 didn't have, and all 3 presented with paraparesis, acute paraparesis. And we all reflexes were there, couldn't find whether it is lower motor neuron or higher motor neuron, upper motor neuron, no level. And then we found out whether it is because of something else. And sickle cell and HB variant analysis by HPLC was done, and we could diagnose that. So very wonderful cases. And as sir has said, that giving vaccination is most important, as hydroxyurea and all the vaccinations, 4 vaccinations we have to give in all this sickle cell disease or sickle cell anemias.
Yes, we have Dr. Naresh. Yes, sir.
Yeah. I wanted to just say that MAHALAB of Maharashtra State does free sickle cell testing. They also give free hydroxyurea at some of the centers. Most PHC are supposed to have hydroxyurea, which is given free of cost. Yeah, then Dr. Naresh Taide is present today.
Yeah, he has raised his hand. Dr. Naresh.
Yes, Dr.
Yeah.
Naresh.
I want to say something because this is related to sickle case. I first congratulate Dr. Vaibhavi for presenting this case very nicely. Few things about sickle cell everyone should keep in mind, because those who not seen routinely sickle cell disease may miss these cases very commonly. One is, it is a very pleomorphic disease. So it can present as any way. So it can present to neurologist, hepatologist, hematologist, or any person, or orthopedician also. Second, it can present at any age, though it is since birth. Patient may present at 3 months, 6 months, 1 year, 5 years, or at 20 years, 22 years, first time without any complaint. Third thing, sudden death is also known with the sickle cell disease. So completely all well child dying suddenly, presenting. So if patient comes with this type of presentation, again you have to suspect the sickle cell disease. One thing about the sickling, what they have said, sickling is a very good test with sensitivity and specificity, but you should not rely for sickling test to diagnose the sickle cell disease. Best test is the HB electrophoresis. So please do HB electrophoresis for diagnosis. And another things, in acute chest syndrome, usually saturation is low. So with 97% saturation at room air, we are unlikely to say it is an acute chest syndrome. It may be due to sudden drop in the hemoglobin. So patient may have some viral illness or any other illness which can cause the precipitation of sickle cell crisis, and due to sudden anemia, patient may have tachypnea. And other findings may be due to just associated respiratory illness. So this may be the possibility rather than acute chest syndrome, because saturation at room air is 97%. In generally, if it is acute chest syndrome, there should be drop in the saturation. So with normal saturation, unlikely to say it is a acute chest syndrome. Fourth thing, we should not every patient with the sickle cell required exchange transfusion. So whether give to simple transfusion or exchange transfusion is depend upon the hemoglobin level. So hemoglobin if less than 6, and if there is an indication, like if this we suspect acute chest syndrome or patient with stroke and sickle cell disease and his hemoglobin is low, or patient with splenic sequestration crisis and his hemoglobin is low, then we can give directly blood transfusion. But if we are keeping the patient with the hemoglobin of 11 or 10 and the patient is presenting as a stroke or patient with the acute chest syndrome, then we have to do the partial exchange or exchange transfusion. So exchange transfusion depend upon the what is the hemoglobin value of that patient, and exchange transfusion should be done in a patient who kept on the transfusion program, like stroke patient where we want to keep hemoglobin S level below 30%. And it is my kind request to everyone, every pediatrician, to please do the HB electrophoresis of every patient. We don't want to diagnose the sickle cell disease or thalassemia disease more, because either you not diagnose, someone other person may diagnose it and treat it. But we want to diagnose, treat much more and advise family regarding prevention in this type of disorder, because prevention is very easy in this patient rather than treating them lifelong. So the early diagnosis, if you do the HB electrophoresis of every patient more than 1 year old once in the lifetime, you can able to diagnose straight and you can counsel the family for prevention. So this is my kind request to everyone. As a pediatrician, we should tell our obstetrician also, and we should start doing these practices. Thank you. Thank you for allowing me to talk.
Thank you, Navi sir, for such important points, sharing with us with such important points. And thank you, Vaibhavi ma'am, for presenting such wonderful case to us. Yeah.
One question, yeah. To Dr. Naresh Taide, sir said it less likely looks like acute chest syndrome because the saturation at room temperature was 97%. But sir, after giving blood transfusion, we had given the blood transfusion in the night, and by morning the child was sitting, eating, and on the rounds we were surprised to see such a drastic change. So if it was not acute chest syndrome, then why should a drastic change occur just after giving one blood transfusion?
That is going to occur.
Our team was in a dilemma of same or whether it is an LRT or acute chest syndrome. But after giving the transfusion and with such a drastic change, we were in favor of acute chest syndrome, sickle crisis. Like
that is going to happen because patient has lethargic due to sudden decrease in hemoglobin rather than his respiratory component. So as you restore his hemoglobin value, patient is going to improve, activity is going to improve, patient distress is going to be decreased, because in simple viral illness, patient may have cough cold. We have seen many patients with cough cold in and they are well. He is lethargic, he is tachypneic, much more likely because of sudden decrease in the hemoglobin. And if we previously know his spleen size and later we have seen this patient may be actually presenting with the splenic sequestration crisis. That may be the cause. Splenic sequestration crisis is one of the major cause of mortality, and patient hemoglobin from 10 may go down to 5, 4, and patient may die if we not recognize early and transfuse them, though with the lower PCV value. So the rate of transfusion in that case may be 5 ml per kg, because once they recover from the splenic sequestration, their hemoglobin rise rapidly.
Okay, sir. Yeah, thank you.
I also want to appreciate the efforts of team Jalgaon, Dr. Avinash Bhosle, Dr. Rahul, Dr. Gajanan. They did an extra job. I think even like the previous team, by third slide, they had already said we want to know about peripheral smear. So I think that was remarkable. So they also came. Yeah, I think Dr. Gajanan.
Actually, sickle is very common in this part of the state because in our medical college also we are getting a lot of these children with sickling. And most of the time, it's our workup that when any child comes to us, we will do peripheral smear. And child is having hepatosplenomegaly with anemia. So definitely considering the community and all those, in our side, these tribal community have very high incidence of sickle and thalassemia. So definitely, even though considering anemia with hepatosplenomegaly, when you told about anemia, hepatosplenomegaly with anemia, so our first thing we will consider as a hemolytic process something. So that's, I think it's very common, not uncommon to say in our side. So that's what we thought of sickle first and then crisis. So those are the things. While we are considering our scenario, definitely we will consider these things.
Excellent. And this patient was from Vaitarna. Vaitarna covers Jowar and Mokhada. Jowar, Mokhada, and those areas, Dahanu, a very high incidence of sickle cell anemia. So although he may be residing now in Virar, if he is originally from Vaitarna, then he is from that Jawar Mokhada area, which is very high incidence of just like Jalgaon team is saying. Excellent. So I think the point said by Dr. Naresh is very important to do HB electrophoresis. Dr. Pramod Kulkarni, your expert comments, please.
No expert comments. Only thing, Dr. Ambedkar must be very heartened with the thing. And now you will get convinced, all the teams are doing so well. And the culture of thinking and clinical skills is very well rooted, even in the third generation now. And that's very heartening. And that is why I always say that we expect every team to crack the diagnosis. We will be surprised if one team fails to do that. And that's the beauty of Dr. Ambedkar's effort, taken ahead by Dr. Mahesh and the other teams, and iconic teacher like Dr. Baldev. Thank you so much. Thank you.
Yes.
Thank you, Kulkarni sir. I agree with you. Now I think so. Everyone is waiting, and Trupti, hand over to you for the vote of thanks.
Yeah. Thank you so much, Dr. Neha. So, hello, respected seniors and dear colleagues. I, Dr. Trupti Mahatme, on behalf of MAHAIP, would first like to thank today's guest of honor, Dr. Vasant Kalatkar sir, for accepting the invitation and giving blessings to us. I would also like to thank today's experts, Dr. Baldev Prajapati sir and Dr. Mahesh Mohite sir, for their valuable inputs, which were really quite helpful. I would like to thank today's presenters, Dr. Abhijit Joshi and Dr. Vaibhavi Barot, for presenting wonderful cases, which really led to brainstorming discussion about them. I would like to thank both the teams, Team Jalgaon, Dr. Avinash Bhosle, Dr. Rahul Patil, Dr. Gajanan Surewar, Team Beat, Dr. Izar Javed, Dr. Anurag Pangrikar sir, and Dr. Sachin Jetlia. I would like to thank Dr. Pramod Kulkarni sir, who is coordinator of Maha Case Challenge, for scrutinizing both the cases in spite of having busy schedule. I would like to sincere thanks to MAHAIP President Dr. Ramakant Patil and Dr. Amol Pawar sir, Secretary MAHAIP, for their wholehearted support to the Maha Case Challenge and giving opportunity to us. I would like to thank Joint Zonal Coordinators Dr. Rajendra Khadke sir for his valuable inputs, Dr. Anjali Gokarn Madam for moderating the session well and also for her contribution towards today's session. Remaining zonal coordinators, I would like to thank Dr. Deepa Firke Madam, Dr. Ravindra Sunavne sir, and Dr. Naresh Taide. I would like to thank today's moderator, Dr. Neha Singh, along with Anjali Madam, for moderating the session well. I would like to thank Dr. Sachin Gaikwad sir, who is being MMC observer for today's session. Lastly, I would like to thank Pallavi Madam for her timely technical support and all the attendees of today's session for joining us on Zoom and YouTube platform. With this, I would like to conclude today's session. Thank you so much.
Thank you. Thank
you. Thank you very much.
Thank you. Good night.
Thank you.
Thank
Very
you.
nice discussion. Thank you very much.
Yeah.
From next time, we'll ask the team to take dinner first and then attend